أنا لما كنت على المنصة ما شكرتش اللجنة المنظمة، فأنا لازم أشكر اللجنة المنظمة. فبشكر الدكتورة مها والدكتورة لمياء والدكتورة سحر والدكتورة ميادة والأستاذ الدكتور علي. تمام، إن شاء الله مش هنطول عليكم. هي الورك شوب دي ICU ورك شوب 4 محاضرات. أول محاضرة إن شاء الله I will highlight the principles of oxygen therapy, delivery systems and monitoring. We all agree that oxygen is one of the most widely used drugs and is used across the whole range of specialties. Mostly all specialties use oxygen or prescribe oxygen for their patients. Oxygen therapy is defined as the administration of oxygen at concentrations greater than that in the room air to treat or prevent hypoxemia. But we should put in mind a very important point that supplemental oxygen is only given to improve oxygenation or hypoxemia, as we said, but does not treat the underlying cause of a hypoxemia, which must be diagnosed and treated as a matter of urgency. Oxygen should be prescribed and monitored in care, and we should put in mind that our ultimate goal is to achieve optimal tissue oxygenation and not maximal oxygenation. Meaning that we should give the patient what is normal and what is safe at the same time. The ultimate goal is the correction or avoidance of tissue and vital organ hypoxia. As we know that prolonged hypoxemia may lead to irreversible tissue injury and organ damage, so our main goal is to prevent the tissue and vital organ hypoxia, and it is documented that arterial oxygen saturation above 90%, above this level, there is no known risk of hypoxic tissue injury. So what is the normal oxygen saturation range in healthy adults? The daytime saturation is 96 to approximately 98% in the seated position at sea level. Normal value also depends on some parameters such as age. Oxygen saturation falls slightly with age and is about 95% in adults aged 70 years. The position, the arterial oxygen is 6 millimeter mercury lower in the supine position, and during sleep, transient dips occurs in saturation are common during sleep. Oxygen delivery system, so how to implement oxygen treatment. Implementation of oxygen needs oxygen delivery systems, which consist mainly of an oxygen source, a pressure regulator and flow meter, which controls the flow of oxygen, and oxygen delivery devices or interfaces, as we know. Oxygen sources, there are 2 sources for oxygen, either central oxygen in hospitals or home oxygen, including compressed gas cylinders, liquid oxygen cylinders, and oxygen concentrators. These are the compressed gas cylinders. These are the liquid oxygen cylinders. They are easier to refill but of higher cost. This is the oxygen concentrator, which consists of this device takes the room air oxygen concentration with about 21% and passes it through many filters to filter any unwanted harmful gases or bacteria or viruses, and it gives the patient an oxygen concentration up to 95% via a flow meter with mask or nasal cannula. This is the pressure regulator with a flow meter, which is found in hospitals. The pressure regulator contains the pressure coming out of the cylinder or the wall source and is indicated on the gauge in pounds per square inch of pressure. And the flow meter contains how rapidly the oxygen flows from the cylinder or the wall source to the patient. Oxygen delivery devices are divided into 2 types: low flow oxygen delivery devices or variable performance, and high flow oxygen delivery devices with fixed performance. The low flow oxygen delivery devices provides only a fraction of the patient minute ventilatory requirements as pure oxygen, and the remainder is fulfilled by usually the room air. Why they are called of variable performance? Because the amount of the fraction of inspired oxygen delivered to the patient usually changes according to the ventilatory pattern of the patient. So in a patient with abnormal or variable ventilatory pattern, there are marked variability in the fraction of inspired oxygen delivered. So if a patient has a shallow breathing, there is less entrained room air with a higher fraction of inspired oxygen delivered, and with deep breathing, more entrained air with lower fraction of inspired oxygen delivered to our patient. Low flow oxygen delivery interfaces include the nasal cannula, simple face mask, partial rebreathing mask, non-rebreathing mask, and tracheostomy mask. This is the nasal cannula. It is the most commonly used, simple, inexpensive. It gives a flow from 1/6 to liters per minute and the fraction of inspired oxygen up to 44%. Increasing the flow more than 6 liters per minute does not raise the fraction of inspired oxygen delivered to the patient more than 44% and may cause drying of the mucus secretions. These are advantages and disadvantages. As we see, there is no rebreathing of CO2, better tolerated, easy to use, disposable with low cost, but the flow must more than 5 liters or 6 liters per minute is not tolerated, may lead to drying of the mucosa. It may cause gastric distension, and actual concentration of oxygen cannot be predicted. As we said, it is of variable performance according to the patient ventilatory pattern. A simple face mask usually delivers oxygen up to 60%. The simple mask requires at least a flow of 5 liters per minute to avoid accumulation of CO2 and CO2 rebreathing. This is the simple face mask with exhalation ports on the sides. Advantages: easy to apply, disposable, inexpensive, but must be removed for eating, speaking, may be blocked by vomitus or secretions, and may lead to drying and irritation of the eyes. And as we said, it can give a fraction of inspired oxygen up to 60%. Partial rebreathing face masks, these are simple masks with additional reservoir bags that allows the accumulation of oxygen for rebreathing, and it has 2 exhalation ports. The reservoir bag must remain inflated, an oxygen flow rate up to 10 liters, and it delivers a fraction of inspired oxygen up to 90%. So this is the partial rebreathing mask with reservoir bag with 2 exhalation ports. The minimum flow should be at least 6 liters per minute to avoid breathing large amount of exhaled gases and CO2 rebreathing. Non-rebreathing mask with reservoir bag. This consists of a face mask, oxygen reservoir, a valve at the exhalation ports for exhalation, and an additional valve between the reservoir and the mask, and gives a fraction of inspired oxygen up to 100%. We'll skip this slide. Tracheostomy mask. These devices are designed to allow oxygen to be given to a patient which has done tracheostomy tube or to patients with previous laryngectomy. Its oxygen flow up to 10 liters, provides accurate fraction of inspired oxygen, provides good humidity, comfortable, and patient may need frequent suctioning to remove mucus from the airways. High flow oxygen delivery devices. Gas flow of the apparatus is sufficient to meet all the patient's inspiratory requirements. A high flow oxygen delivery system maintains the selected inspired oxygen by delivering oxygen at a very high flow, which exceeds the patient's peak inspiratory flow rate. These include the Venturi mask, the oxy hood and oxygen tent, ventilators, either invasive or non-invasive, and high flow nasal cannula. In Venturi mask, it is often employed when the clinician has concern about CO2 retention. So it is used mainly in patients with hypercapnic respiratory failure. Type 2 respiratory failure is in patients of COPD. 2 more common indications: treatment of hypoxic patients who depend on their hypoxic drive to breathe, which requires controlled oxygen, and young vigorous patients with hypoxemia who have an abnormal ventilatory pattern and whose ventilatory requirements may exceed the capabilities of lower flow systems. And these colors may be variable, they are not constant. It consists of a mask with a jet of variable sizes with exhalation ports for exhalation, and it gives from 2 liters per minute up to 15 liters per minute with a fraction of inspired oxygen up to 60%. These are usually used in pediatric patients, known as the oxy hood and oxygen tent. Ventilators, whether invasive or non-invasive, can give up to 100% oxygen under positive pressure, and it is used if the patient is deteriorating, the pH is decreasing, the CO2 is rising, and the patient is drowsy and with persistent hypoxemia. High flow nasal cannula. I will skip this part عشان الدكتورة لمياء هتقول high flow nasal cannula in the upcoming lecture. So what is our target oxygen level? Use titrated oxygen therapy. Titrated meaning stepping up or stepping down accordingly. In hypoxemic respiratory failure, the target arterial oxygen saturation is 94 to 98%, and in patients with hypercapnia, the target saturation is 88 to 92%. Why not give 100% oxygen? As we said before, our ultimate goal is optimal oxygenation, not maximum oxygenation, because too much oxygen for longer or prolonged periods of time may be hazardous or dangerous. So our goal is the physiological oxygenation, not maximum oxygenation. So we should avoid acute rise in oxygen level. This may cause VQ mismatch, decreased ventilatory drive, absorption at elected higher density of oxygen compared with the room air may increase the work of breathing. These are the PTS recommendations for prescribing oxygen, and it has 4 classes, as we see. First class are patients with critical illness requiring high levels of supplemental oxygen, and these include patients with cardiac arrest, major trauma, active convulsions, anaphylaxis, carbon monoxide poisoning, major pulmonary hemorrhage, sepsis, and shock. So if a patient has a post-cardiac arrest or has gone through cardiac arrest, initially give the highest possible oxygen concentration up to 100%, and when the arterial oxygen can be measured reliably, titrate the oxygen saturation to 94 to 98%. Class 2 are moderate levels of supplemental oxygen are needed if the patient is hypoxemic. In case of acute hypoxia, whatever the cause, acute asthma, acute heart failure, pneumonia, lung cancer, post-operative breathlessness, pulmonary embolism, massive pleural effusions, tension pneumothorax, severe anemia, and sickle cell crisis. And if the saturation is less than 85%, we use the non-rebreathing mask with reservoir at flow 10 to 15 liters per minute. And if it is between 85 to 93%, give a nasal cannula of 2 to 6 liters per minute. The third class, the patients who require low-dose oxygen or controlled oxygen therapy. And this class includes the COPD patients and non-COPD patients that are at risk of developing hypercapnia or has hypercapnic respiratory failure. Non-COPD patients at risk include cystic fibrosis, bronchiectasis, often associated with COPD or severe asthma, severe kyphoscoliosis or severe ankylosing spondylitis, severe lung scarring from old TB, morbid obesity, body mass index more than 40, musculoskeletal disorders with respiratory muscle weakness and overdose of opiates, benzodiazepines, or other respiratory depressant drugs. If blood gases are unavailable, use controlled oxygen with 28% Venturi mask at 4 liters per minute, and the aim of oxygen saturation, as we said, is 88 to 92%. Adjust the target range to 94 to 98% if the PaCO2 is normal, so there is no hypercapnic respiratory failure, unless there is history of previous non-invasive or invasive positive pressure ventilation, and recheck the blood gases after 30 to 60 minutes. To avoid hypercapnia and acidosis in those patients, target the arterial oxygen pressure less than or equal 75 millimeter mercury and a saturation less than 92%. And as we said, 88 to 92% is very acceptable in those patients. As we said, maintain an oxygen range between 55 to 75 millimeter mercury to avoid hypercapnia and acidosis. And the oxygen dose should be reduced if the saturation exceeds 92%. Rebound hypoxemia. If the patient is severely hypercapnic or develops a severe hypercapnia due to excessive, do not stop oxygen therapy abruptly. Instead, it is safe to step down the oxygen gradually if the patient is fully alert, or to provide mechanical ventilation if the patient is drowsy or deteriorating. And the fourth class and the last class, no oxygen is required in these patients until hypoxemic. And those include myocardial infarctions, acute coronary syndromes, stroke, cardiac rhythm disturbance, non-traumatic chest pain, pregnancy, abdominal pain, headache, hyperventilation, metabolic and renal disturbances, post-convulsion, gastrointestinal bleedings, glycemic emergencies, and heat stroke. So if the saturation is less than 85%, use a non-rebreather reservoir mask with a flow 15 liters per minute, or if it is between 85 to 93%, use nasal cannula 2 to 6 liters per minute, and aim for a target oxygen saturation 94 to 98%. Why we don't give oxygen except if hypoxemic? Because oxygen may deteriorate the case. For example, in cerebrovascular stroke, lactic acid accumulates in the neurons. The acidic environment has a pro-oxidant effect, and reactive oxygen species can further damage an already vulnerable neuron. So give oxygen only until hypoxemic. For example, in acute coronary syndrome, excess oxygen therapy may lead to increase in blood pressure, low coronary blood flow. Despite higher oxygen, there may be reduced tissue delivery, so do not give oxygen until hypoxemic in those conditions. when not to titrate oxygen or to step down so we can give safely 100% oxygen in 3 cases: traumatic brain injury, carbon monoxide poisoning, and pneumothorax. Patients with traumatic brain injury may need higher than normal oxygen to provide enough oxygen to the brain. The goal oxygen saturation is 100%. In carbon monoxide poisoning, carbon monoxide binds, as we know, to hemoglobin and displaces oxygen. So high flow oxygen causes more rapid elimination of the carbon monoxide molecules. So the goal is 100%. And in pneumothorax, high concentration of oxygen is recommended. معلش Pneumothorax, high concentration, as we said, enhances the air absorption unless the patient is at risk of hypercapnia. So the target is 100%. Strategies for improving oxygenation. So if we want our patient to have the optimal oxygenation, we should optimize oxygen delivery and optimize the oxygen carriage, and these 2 factors depend mainly on the hemoglobin level of the patient. So this is the equation for oxygen delivery. DaO2 is the oxygen delivery, the arterial content of oxygen, CaO2, and Q, it should be QT correctly, which indicates the cardiac index. So in the equation, there is the hemoglobin. So this depends on the hemoglobin level. 1.34, this is the volume of oxygen carried by 1 gram of hemoglobin when it is 100% saturated with oxygen. Optimizing oxygen carriage, the ideal hemoglobin level is still debatable, but it is documented that hemoglobin levels not below 10 gram per deciliter may optimize the oxygen carriage. I'll skip these slides. Monitoring during oxygen therapy. Monitoring usually by pulse oximeter, which is usually now available in the ward and emergency room, and it is known as the 5th vital sign, so it is very necessary to be available all the time. Blood gases is indicated only in critically acutely ill patients, unexpected hypoxemia, deterioration in a patient with previously stable, breathlessness at risk of metabolic conditions, patients with poor peripheral circulation. Monitoring during the first hour, all patients should have their oxygen saturation observed 5 minutes after starting oxygen. If the saturation falls below the target saturation, increase the oxygen therapy. If saturation fails to rise, 5 to 10 minutes after increasing, arterial blood gases should be checked. If the saturation is above the target range, oxygen therapy, we can step down with the oxygen therapy. Patients with target saturation of 88 to 92%, those are at risk of hypercapnic respiratory failure. Arterial blood gases should be done within 30 to 60 minutes. Stable patients, a pulse oximeter is sufficient. Weaning, either to step down or to step up. Step 1, stepping down, lower the oxygen concentration. If the patient is clinically stable and the saturation is above the target range for at least 4 to 8 hours. Continue stepping down if the target saturation is maintained, and the new delivery system and the flow should be continued the same. If the patient is stable for 1 to 4 hours, the process can be repeated. Step down to 2-liter-minute via nasal cannula prior to cessation of oxygen therapy. Patients at risk of hypercapnia, step down to 1 liter per minute via nasal cannula or a 24% Venturi mask. Stop oxygen therapy. Oxygen should be stopped if the patient is clinically stable in the lowest concentration of oxygen and the oxygen saturation is within the desired range on 2 consecutive observations, usually 1 to 2 hours apart. Monitoring on room air, this is the last step. Oxygen saturation on air should be monitored for 5 minutes. If remains in the desired range, it should be rechecked at 1 hour. If oxygen saturation and the patient is clinically stable and satisfactory, at 1 hour the patient has safely discontinued oxygen therapy. When to step up with oxygen if the saturation falls below the target range on stopping oxygen therapy. Restart the lowest concentration that maintains the target range and monitor for 5 minutes. If this restores saturation, continue oxygen therapy and attempt discontinuation at a later date. So take-home messages briefly. Oxygen therapy saves life. The selection of an appropriate oxygen delivery system or interface is very important, which depends mainly on the clinical condition of the patient size and needs, the therapeutic goals. As we said, oxygen therapy has some risks and hazards, but as a rule, advantages of oxygen far outweighs its risks. Weaning oxygen, if oxygen saturation is in the upper zone for at least 4 to 8 hours, step down to 2 liters per minute via nasal cannula prior to cessation of oxygen therapy. In patients with hypoxemic respiratory failure, patients at risk of hypercapnia, step down to 1 liter per minute via nasal cannula or a 24% Venturi mask. And thank you.